Hello and welcome to my channel. Today I'm going to start a new series in which I will be explaining MCQs from the Lange textbook, and very first topic is trauma. So the very first MCQ states that there is a 20-year-old unrestrained driver who had a motor crash accident. A CT scan demonstrated a large hematoma in the second portion of their duodenum. The rest of the abdomen is normal. Now the question is asking that what is the initial management in case of a duodenal hematoma? So should there be an operative evacuation, nasogastric decompression with intravenous fluids, ERCP, laparotomy and different procedures, or octreotide? So the answer is B. That is, there should be only nasogastric decompression with the use of intravenous fluids and gradual resumption of oral diet. So in the explanation, it states that intramural hematomas occur secondary to blunt trauma of the appendix. Usually, duodenal hematomas are submucosal, they are not transmucosal, and that is why they only cause temporary obstruction. So, they are treated with conservative measurements like nasogastric suction, intravenous fluids, and only patient who presents or contains persistent obstruction beyond 2 weeks will require a surgical management. So as we know that duodenum is a C-shaped structure, it has 4 parts, and this explains that blunt trauma is going to cause some injury, and usually this injury, as we know that there are different layers of the ball, there is mucosa, submucosa, and there are different layers. Usually the duodenal hematomas are submucosal, and this is the reason why they are managed conservatively. So the next statement says that the patient had a motor crash and a CT was performed, and the CT scan is showing a peripancreatic hematoma with an indistinct pancreatic border. So this is a trauma MCQ in which pancreatic injury is being assessed. So what is the actual question? What is the most definitive test for identification of pancreatic injury that is requiring an operative intervention? So the options are ERCP, ultrasound, CT scan, operative exploration, or amylase test. The answer is ERCP. So the most definitive test in a lesion to identify major pancreatic duct injury. So major pancreatic duct injury is one of the indications for operative management for pancreatic trauma. And how to identify it? We have ERCP. Though CT scan can be helpful in identifying ductal injury, but ERCP is more specific and more reliable to identify a disrupted duct. I have explained pancreatic injury in a different lecture. I will give the link in the description so that you can have a complete understanding of the pancreatic injury as well. So a 30-year-old restrained driver was involved in a motor vehicle crash. He is hemodynamically stable and has a large seatbelt sign on the abdomen. On examination, the abdomen is standard to palpation. In this patient, one should be concerned about. So there is a patient who had a crash, yet he is hemodynamically stable and their abdomen is standard and they have a seatbelt sign. So should they be having a liver and spleen injury, or there is transaction of the head of pancreas? Could there be renal pedicle avulsion, hollow viscous injury, or pelvic fracture? So in this scenario, hollow viscous injury is going to be our answer. While all of these injuries can be potentially present, but in case of a blunt abdominal trauma, we should be suspecting viscous hollow injury. A diagnosis delay of 12 hours can be associated with increased morbidity and mortality. There are very few physical signs of viscous perforation, and CT can be non-definitive in this scenario. So, as I've explained, a seatbelt across the abdomen in case of a hemodynamically stable patient, we should be aggressive in making our diagnosis. Next question is, a 45-year-old man skidded from the road at a high speed and hit a tree. Which of the following is the example of a deceleration injury? Would it be an aortic valve rupture, kidney injury, posterior dislocation of the shoulder, mesenteric avulsion, or stomach rupture? Out of these, the best example for a deceleration injury is going to be the mesenteric avulsion. So, deceleration injury is when a body is moving at a high speed, but they are stopped by a object in such a way that the impacting part of the body suddenly stops, but the organs continue to move like it is simple physics. So, in such a scenario, there is a chance that there could be an injury to the junction of the mobile as well as fixed part, and the best example is the mesenteric avulsion injury. So other choices are also possible, but they are less common. So the more common option is the mesenteric avulsion. So next question states that there is a 25-year-old man who fell from his bicycle on a concrete wall on the left side. The ultrasound shows free fluid in the abdomen, and a CT scan confirmed grade 3 splenic injury. So what is the person? What is the important contraindication for non-operative management, or in other ways, which of the following option will be the indication for the surgical management? It is very important to understand the question because using these different words can make it difficult to understand. So, the options are hemodynamic instability, active bleed on the CT, adult patient in itself, lack of availability of the blood for transfusion, or extensive associated injuries. In this scenario, the most important contraindication for non-operative management is hemodynamic instability. So active bleed on CT scan is followed with embolization, and rest of the options could be used as relative indications, but the most important is hemodynamic instability. So I have explained splenic injury in my handwritten trauma notes. Kindly consult that video for a better understanding of this MCQ as well as splenic injury. So next question is that there is an 18-year-old man who is brought in the emergency after having a stab wound. So the patient had a stab wound in the 6th intercostal space. On examination, the blood pressure is 80 by nil. Faint heart sounds and pulses paradoxes are noted. On auscultation, the right chest reveals decreased breath sounds. So the question is asking that what is the initial management of this patient? Should it be aspiration from the right chest cavity, aspiration of the pericardium, going for the echo, pericardial window, or insertion of a central venous line? So first of all, it is important for us to establish the diagnosis. As the patient is in shock after a stab wound injury on the right side, and there is fainting of the heart sounds and pulses paradoxes positive. So the most likely diagnosis in this scenario is going to be cardiac tamponade. And in case of this shock, it is required to remove the accumulated blood from the pericardiac space. And for that, the immediate step is pericardial decompression that is done by the aspiration from the pericardium. However, there could be a suspicion of tension pneumothorax. This will be followed by aspiration of the right chest cavity with the help of a chest tube. So a 60-year-old woman runs her car into a telephone pole. She presents to emergency with severe anterior chest pain, and the blood pressure is 110 by 80 millimeter of mercury. A chest X-ray shows questionable widened mediastinum. Now, what is the next step in the management? So up till now, we have established that this widened mediastinum is one of the indications that there could be a aortic injury. And there's a second point that the patient is hemodynamically stable. So in case of a widened mediastinum in which the patient is stable, what is going to be the management? It would be transthoracic echocardiogram, pericardiocentesis, aortogram, CVP line, or CT chest. So the answer is that CT chest is going to be a reliable investigation to help us identify the level and degree of aortic injury. So a widened mediastinum has a strong suspicion of traumatic aortic injury. In hemodynamically stable patient, the current guideline says that the CT angiogram is the best diagnostic test. However, aortogram was previously the gold standard, but it has been replaced by the CT angiography. So this is the new intervention according to the latest guidelines. So next question is, there is an 18-year-old man who presented to the emergency with a gunshot wound in the left chest in the anterior axillary line in the 7th intercostal space. So the patient is having injury on the left side in the anterior axillary line in the 7th intercostal space. So axilla can be divided into different parts. There is an anterior axillary line, there is a mid axillary line, and there is a posterior axillary line. So now there is a rushing sound which is audible during inspiration. So by far you can understand that the gunshot wound has resulted into an open chest injury in the 7th intercostal space in the left chest. So what is the immediate or initial management in this patient? Exploratory laparotomy, exploratory thoracotomy, lurocentesis, closure of the hole with sterile dressing, and insertion of a chest tube. So in this scenario, the immediate management is closure of the hole, as this is a scenario of the open chest wound injury and it is initially managed by the closure of the hole, followed by insertion of the chest tube at a distal site to prevent the tension pneumothorax. Laparotomy and thoracotomy are going to play a definitive role, but they have asked that what is the immediate management or the first line management. That is going to be option D. So a 25-year-old man is shot in the left lateral chest. In the emergency, his blood pressure is 120/90. His pulse is 110. His respiratory rate is 36. So this is a case of gunshot wound. Chest X-ray is showing air fluid levels in the left pleural cavity. Nasogastric aspiration has revealed that there is blood-stained fluid. So the question states that what is the best step to rule out esophageal injury? Either it is going to be insertion of a chest tube, insertion of a NG tube, esophagogram with the use of a gastrographin, esophagoscopy, or peritoneal lavage. So in case to identify the esophageal injury in case of blunt or gunshot wound, the best investigation is esophagogram with the help of gastrographin. Gastrographin is a water-soluble contrast. It is less irritating to the mediastinum and it identifies leak in the esophagus. It gives us not only the location but also the amount of perforation that is present in the esophagus. However, if a gastrographin study is negative, then a barium swallow or esophagoscopy can be followed. So if in case there is no option of esophagogram, then you can identify an esophagoscopy as the best option.